Welcome to our video on working with traumatic bereavement. In this video, we'll focus on using cognitive therapy for PTSD to treat PTSD that arises as a result of traumatic bereavement. PTSD after traumatic bereavement can block the natural grieving process, making it difficult for the surviving person to move on. They may have the impression that the dead person is stuck at the time or place of the trauma, or that they're still suffering. The memories may have a strong sense of nowness. They may have images or appraisals linked to the appearance of the dead body, or images or appraisals of the death being undignified, or images or appraisals related to the funeral. PTSD after traumatic bereavement can make it very difficult for patients to remember other memories of the deceased, and so they're left with the loss and over-remembering the trauma associated with the loss. This leads really to the key question: when the worst happens, that is, when a loved one is killed or dies, can cognitive therapy for PTSD be applied to this extreme trauma? And the answer is yes. The factors that maintain PTSD for traumatic bereavement are the same that maintain PTSD after other trauma. What I'd like to draw your attention to on this slide is the model in the bottom right-hand corner and the circled box in red, the trauma memory. Core features of the trauma memory in PTSD after traumatic bereavement include intrusive memories of the death, which typically predominate, with patients having little access to memories of the deceased from before the trauma. The hotspots, the worst moments of the memory, and their meanings are commonly linked to appraisals that the deceased suffered or is still suffering, or that the client could have done more to prevent the death. When there is death by illness, the memory can span many months and include many worst moments. The patient may not have been present at the time of death, and the memory may include images that did or did not happen. Turning to appraisals, we see that in traumatic bereavement, the appraisals are often about the nature of the death, the patient or others being responsible for the death, appraisals about life having no meaning after loss, that the patient has permanently changed for the worse, or appraisals may be about other people's responses. These appraisals link to cognitive themes of guilt and self-blame, loss, permanent change, and often anger. Turning to unhelpful strategies to control the sense of threat, the bottom box circled in red on the right-hand bottom of the slide, we see that patients commonly ruminate about the trauma, the death and the events leading up to it, and the events that follow. They often avoid the trauma memory and avoid sharing their loss, and they may engage in proximity-seeking behaviors, such as visiting the gravesite many times a week, or keeping the room the deceased slept in exactly the same as before they died. The patient may also engage in excessive checking to keep themselves or loved ones safe. So these are our key interventions for working with PTSD after traumatic bereavement. They may not always happen in exactly this order, and some run throughout the treatment. Remember, these are components of cognitive therapy for PTSD. Other components of cognitive therapy for PTSD, such as stimulus discrimination, or then versus now, are also used in treating PTSD after traumatic bereavement. However, they're used in the same ways we would address triggers for other trauma, and so I won't focus on them here. I'll just focus on the key interventions which have nuances when we treat PTSD after traumatic bereavement. So with psychoeducation and normalization, the main message we want to get across is that PTSD after traumatic bereavement is common. Many people who suffer traumatic bereavement will develop PTSD. We also want to normalize emotional reactions such as grief, anger, and relief. When people have been looking after a very ill loved one for a long period of time, there can be a sense of relief when they die, and this is, of course, normal. It's also important to show interest in the deceased and in the relationship your patient had with them. Find out more about the deceased and their whole life, including looking at photos. This helps to contextualize the trauma memories so they're not just the moment of death and can help people retrieve a wider range of memories. There are various things that can help, including doing a family tree and discussing the deceased relationship with other people too. Did they ever disagree? We're aiming to guide the client to experience the deceased as a more rounded person than only their relationship with them or their moment of death. Importantly, it's so important to acknowledge loss and to empathize. This helps to normalize distress. And as a general point, we would recommend not rushing into cognitive restructuring or hotspot work. So rebuilding life begins in the first session. You'll likely need to address blocking thoughts to carrying out a rebuilding life activity. Typical ones include, I shouldn't be enjoying myself, I don't deserve to sit still or relax. All the memories will come flooding back in if I stop keeping myself busy. We would normally address these blocking thoughts by planning a behavioral experiment for the patient, such as taking a short tea break for 5 minutes rather than keeping busy, and seeing what happens. Are they able to relax? Do the memories come flooding back? Are they able to treat them like a train going through a station? A strategy for dealing with unwanted memories covered in the first session. We may also plan behavioral experiments to create new beliefs about life continuing to have meaning without the deceased. For example, the patient may experiment with taking a quiet walk with a friend and tuning into what they can see and hear rather than on what they have lost. They may spot there is beauty in the flowers they see or in the birds they hear, and that beauty can blossom even in loss, and that their life too experiences peace in those moments. Turning to appraisals, the same tools we use when addressing cognitive themes associated with other trauma, we can use when working with PTSD linked to traumatic bereavement. For guilt and self-blame appraisals, for example, I should have done more to prevent their suicide, we would use surveys, pie charts, and guide the patient to focus on everything they did that was helpful. We may also use imagery techniques, which I'll cover a little later in this video. For anger appraisals, such as the doctors didn't give him enough pain relief, they made him suffer, we would listen and show empathy first. An anger letter may be helpful, and we would look at the costs and benefits to the patient of being angry. Who does anger really hurt? Turning to permanent change appraisals, such as I'm permanently changed for the worst, we would empathize. Consider what is possible in the future and what has not been lost, and what the deceased would want for the patient. When the main theme is loss, when there are loss appraisals about the loved one, such as they're gone forever, I've lost everything, we would elicit the meaning of the loved one and consider how to take the meaning forward in imagery, how to create continuity. We would transform loss images, and I'll cover this shortly in this video. When the patient has appraisals that the deceased is still suffering, they're not at peace, or they've been dishonored, there are points worth considering. It's helpful to consider the religious beliefs of your client, their cultural beliefs and rituals around their death. What are their thoughts of the afterlife? What are their thoughts about the duration of suffering and the death of their loved one? The near-death video, which features Peter Fenwick, who was based at King's College London, explores the experiences of people who medically died and who were resuscitated. The video explores their experience of death before they were revived. The video gives information which patients may find comforting, and you'll find extracts of it on YouTube. It may also be helpful to consult faith, community leaders, medical experts, or police reports if there are meanings around violation of religious and cultural rules or circumstances of the death. Turning to updating memories, we elicit the meanings of death, such as self-blame, regrets about things said or not said, of life no longer having meaning, for example, and discuss them before memory work. Imagery is important for updating meanings of hotspots, and I'll be showing a video of this shortly. We often need to discuss beliefs about the afterlife and cultural beliefs about death for updating. So we would address cognitive themes first. We may use narrative writing with the patient if the trauma was very long, such as treatment in hospital. We update worst moments with new information. For example, his contorted face was a reflex. He was not suffering. And imagery can also be used to help update worse moments. For example, we would want to run images on from an image of a loved one suffering to an image that represents the loved one is no longer suffering. They're at peace and always with the patient. There are 5 steps to transform distressing loss images. The first step is to identify the image. For example, this may be my sister in the hospital bed struggling to breathe. The second step is to consider what is the meaning of the image. And this may be, for example, my sister was alone and suffered. The third step is to consider what updates the meaning. For example, the new information may be the nurses were by the person's side when they died. If the patient died alone, the new information may be they're no longer suffering. The fourth step is to consider what new image represents the updating information. So this may be picturing nurses by the person who died by their side. Or if the person died alone, an image that represents they're at peace now. And finally, the fifth step is to transform the image to the new image. For example, first the patient would picture the distressing image, then bring in the new information and run the image on to the updated image. For example, picturing nurses next to the person who died. We shift the focus from they're not here anymore to how can I take them with me? When the patient has concerns that their loved one is still suffering or has many images of their loved one suffering, we may use imagery to run the image of suffering on to an image of the loved one in a place of peace. This will involve asking questions such as, where would you like your loved one to be? And we'll obviously need to discuss with patients their beliefs about the afterlife. We may use imagery to say goodbye or to say hello to the deceased. If saying goodbye, the process is similar to imagery rescripting. We also identify updating imagery and link to hotspots. This is perhaps one of the more common uses of imagery when treating patients with PTSD after traumatic bereavement. So this video shows the therapist working with the patient to discover updating information and linking it to her worst moment of her sister's death. So what I'd like to do in this part of the session is to really explore the meaning of Kate to you, what she brought to your life, what she brought out in you, because I expect this will help us to identify some really important information that perhaps we could capture in an image to represent her meaning that you can take forward with you. So shall we take a few minutes to really kind of like look at what Kate brought to your life?
So much. I mean, where to begin? She brought so much joy, I guess, and love to my life.
Lovely. She sounds like a wonderful person. Wondering what qualities she brought out in you.
Kate was, without a doubt, the kindest person you'd ever meet. Like, she'd do anything for anyone. And she made me a kind of person. Like, she was always dragging me off to help someone. Yeah, she just made me a kinder, better person, I think.
She sounds like a wonderful sister, and she brought kindness out in you, and she was very kind herself. What did Kate mean to you?
She meant joy and love, and I guess she always tried to see the positive in things. You know, she was such a positive person.
Lovely. She really sounds like a wonderful person. You're doing a great job. I'm wondering if we can think of an image, create an image that might capture what Kate means, what might capture the positivity, her love, her joy. What image comes to mind?
It's hard, but the first thing that popped into my head when you said that was we used to sit on her balcony together, and it was a massive sun trap, and we'd just laugh and like have really funny nights there. And I guess maybe the sunshine, like the sun shining brightly, you know, kind of for me captures her in many ways.
Sounds lovely. That sounds perfect. So the sunshine captures Kate, her positivity, her warmth, her love. That all, I can see how the sunshine would capture that. That's really beautiful. I'm wondering maybe if we can bring to mind an image of sunshine now and just really get a clear picture in mind, your mind's eye of what that looks like.
Mm-hmm. Yeah, okay. I think I've got something.
Can you describe it to me?
I'm actually seeing her balcony, just really full of light. Yeah, just that really reminds me of just the kind of lovely fun like we would have together and what she meant to me.
Lovely. Sunshine beaming down on her balcony. That's a really lovely image. So what I'd like us to do is to go back to the worst moment, bring in that updating information that we've worked on quite a bit already and gone through quite a few times in the trauma story. But I think I'd also like us to really then move that image forward to include the image we've just worked on now, which captures the meaning of Kate, how you'll take her forward. Does that sound okay?
Yeah, we can try that.
Yeah. Okay, so it'll be the sunshine image. So if you'd like to take yourself back and just talk me through that moment where you hear that she's died and the image you have in your mind.
Okay. So the phone rings and they tell me, and my heart just sinks. And what pops into my mind is this horrendous image. I'm seeing Kate in the bed, and she's on her own. She's suffering.
What do you know now, Liz?
I know now that two very kind nurses were with her, holding her hand, that she was on pain medication, she wasn't suffering, that she's at peace now. That she had my bracelet with her.
Lovely. And did you speak to her?
Yes, I'd spoken to her many times in hospital, and earlier that day. Yeah.
So she didn't die alone, and she's no longer suffering. Okay, and I'd like you to just run the image on to include the image of sunshine, Kate's warmth and love and joy. Can you get a good clear picture of that in your mind's eye?
Yes, okay. So I'm picturing that balcony just bathed in light. And to me, that's her warmth, her joy, her love. Whenever I see the sun now, she's still with me.
That's beautiful. Well done. Really well done. How distressing out of 100 was it to go through that moment just now where 100 is very distressing and 0 is not at all?
It felt much better, actually, doing it this time around. I would say a little, maybe 10%.
Okay, well done. And how now did that moment feel where now 100 is very now? It felt like it was happening all over again, and 0 felt very much like it was in the past.
I would say it felt very much like it was in the past, so 0%.
Well done. Lovely. It's a lovely image, the sunshine on the balcony. I'm wondering if you can call that to mind during the week.
I will, definitely, yeah. I have a nice little spot in the garden that's really sunny that I'm going to go and sit in after this session, I think.
Lovely, well done. So the process of transforming worst moments with imagery involves 4 steps. The first step is to identify the meaning of the worst moment. For example, this may be, I'm alone, Kate is gone forever. The second step is to consider, what did the loved one bring out in you? What does she mean to you? For example, in the video we just saw, this would be so much joy, positivity, and kindness. The third step is to consider, what image represents the meaning today? In the video we just saw, this was sunshine. The fourth step is to link the image that represents continuation to the relevant worst moment. For example, in the video we just saw, picturing Kate in the hospital bed and then running the image on to an image of sunshine. Imagery can be used to help the patient when they're struggling with things that have been left unsaid to their loved one. We would have the patient call to mind a place where their patient enjoyed time with their loved one. We would ask, is there anything you would like to say to your loved one? Is there anything she would like to say to you? Is there anything she needs? Is there anything you need? And the process continues until it feels complete for the patient. Imagery can also be used when the loss is conflicted, and the focus would be on creating an image to represent the best meaning of the person. Turning to unhelpful strategies to control the sense of threat and how we may work with them, on this slide you'll see the most common strategies patients with PTSD after traumatic bereavement engage in and how to address them. To target rumination, we would elicit the advantages and disadvantages, use a metaphor to help patients discover the harmful effects of rumination, guide clients to label their rumination, and develop a plan with them to disengage from ruminating when they spot it. This may involve switching their focus from thinking to the environment or to a rebuilding life or self-care activity. For avoidance of the memory or of sharing the loss, we would use guided discovery and behavioral experiments where patients may experiment with sharing their loss with a friend to discover what happens when they share rather than avoid speaking about it. To address proximity-seeking behaviors, we would use guided discovery and behavioral experiments, helping the client to experiment with visiting the gravesite less often, for example, and instead trying a rebuilding life activity or calling to mind an image of their loved one at peace to discover and see how this makes them feel. For excessive checking, we would work with overgeneralized sense of danger, calculate risk with sequential probabilities, spot safety behaviors, and encourage clients to drop the safety behaviors, such as the excessive checking, when they carry out their behavioral experiments. In this video, we hear a client's updating information that she found incredibly helpful in cognitive therapy for PTSD for her traumatic bereavement. Her husband had died from cancer, which had been misdiagnosed for a year, so his deterioration and death was rapid.
We added updated information to my story about Paul not suffering anymore, about the warmth and his love for life, about taking that forward. There was also a song that showed that was sort of epitomised his love for life. It was a Northern Soul song, and my therapist sent this to me on a flashcard, which I carry around with me everywhere, which just, when I read it, and I do read it a lot, makes me smile, because it makes me remember him, how before the trauma, before the illness, before all of that happened, it just reminds me of him being full of life and happy, and it makes me smile. And that's all I can, what more could you ask when that you remember your loved one and you smile? You can't, with what's happened, that's a really good result.
So just to wrap up, cognitive therapy for PTSD can be used to treat PTSD after traumatic bereavement. As with PTSD after other trauma, we address maintaining factors, appraisals, the trauma memory, and the unhelpful strategies control the sense of threat. We guide the client to shift their focus over time from the belief they're not here anymore to how can I take them with me. Imagery is very important in this process and is used to transform painful meanings linked to loss and distressing loss imagery. Thank you for your attention. There is more information on the oxcatoutresources.com website.